So let's move out of the stage 3 setting and into the stage 4 setting, where immunotherapy has been, I think we're all using it either in second line or in combination with chemotherapy. The single agent checkpoint blockades are firmly cemented initially in the second line after chemotherapy in the refractory setting, and of course now have more recently moved front line in combination with chemotherapy. We've got KEYNOTE-189, which was a real game changer and recently published, showing benefit. And we've also had some data at this World Lung in Toronto with Empower 132. Suresh, you want to walk us through these two data sets, and maybe we can try to distill how to use this data in our clinical practice?
So as you started talking about the advent of immunotherapy in the second line setting, we've had multiple agents approved. The field has now quickly shifted to the front line setting, and that's where we're trying to figure out what's the best way to use the immune agents with chemotherapy or by themselves based on biomarkers. In the frontline setting, now we have multiple clinical trials that have read out that combined chemotherapy with immune checkpoint inhibition. Now, we've also had trials comparing combination of immune checkpoint inhibition with another immune active agent like CTLA-4 targeted drug and comparing that to chemo. So as we focus on the chemotherapy-based combinations, the KEYNOTE-189 trial that was reported about 6 months ago and has been published in the New England Journal clearly showed that for non-squamous patients, when they received chemotherapy plus pembrolizumab compared to chemo alone, there was a substantial improvement in overall survival and progression-free survival. And we were all surprised with the hazard ratio for overall survival, close to 0.5, which is unprecedented. And that really changed the landscape in a swoop in North America, and I'm sure it's going to change in other parts of the world as well. So it's an approved regimen in the US. The question then is, does every patient with non-small cell lung cancer who has stage 4 disease, non-squamous histology, need all 3 drugs, platinum doublet, in this case carboplatin, pemetrexed, with pembrolizumab? There, we feel that for a subset of patients who have really high PD-L1 expression that's greater than 50%, pembrolizumab alone may be sufficient to get the desired outcome. Well, our desired outcome is cure. We're not there yet, but when you look at all the agents available, which one gets you the best possible outcome at the least expense of toxicity? So there, for our 50% or greater patients, the KEYNOTE-24 results still hold good, where pembro alone was superior to chemotherapy. The hazard ratio was very robust for both PFS and overall survival. So now we've broken down the patients into those with high PD-L1 and those with low or absent PD-L1. In the low PD-L1 group, which is the less than 50% group, I think the chemo plus pembro approach makes a lot of sense based on the results of the 189 study. What we learned at this meeting is another triplet, which is cis R-carbo pemetrexed with atezolizumab, a PD-L1 monoclonal antibody, also showed favorable results compared to chemo alone. In this trial, the PFS results were very strong. The hazard ratio was 0.6. The results are still early for survival. The overall survival hazard ratio was about 0.8. It didn't reach statistical significance at this point. We have to wait and see as more follow-up matures whether that changes or not. But all the trials are showing us the same direction with varying degrees of benefit. And this, again, will lead to the point of what is the best way to select patients, what's the best biomarker. Is PD-L1 expression the best biomarker? I think as of today, that's the best biomarker we have. The tumor mutation burden is another biomarker that's coming up, and I'm sure we can talk about that as we proceed with this discussion. But for now, I would say that the chemo plus PD-1 inhibition approach, pembro in the US is approved for non-squamous in the front line, is firmly entrenched for the less than 50% population. And for the greater than 50, pembro alone is appropriate therapy.
Let me ask just one question on that, and then I want to get the global perspective on the triplet therapy. Is there ever a time, if the patient has a PD-1 greater than 50, that you would offer triplet therapy and not single-agent pembro? Is that the patient who's symptomatic, who's got a heavy burden of disease, or do you generally stick by single-agent pembro for greater than 50, triplet therapy, carboplatin, pemetrexed, pembrolizumab for the less than 50s?
Right. I mean, in conversations with colleagues and at tumor boards, we talk about this a lot. Does a patient who has very symptomatic disease, who has bulky disease burden, do you give all 3 drugs so you maximize the chance of response? Remember that all three drugs also has a higher likelihood of developing adverse events, and the patient who has a lot of symptoms and has heavy disease burden is also the patient that's likely to experience some of these adverse events. So I have not felt compelled to give all three drugs just based on some of those factors. My approach has been pembro alone has been pretty good for these patients who have really high PD-L1 expression. Now we can look at it and say if a patient has 100% PD-L1 expression versus 51%, would that change? And that's a patient-to-patient decision. Yeah. For a large number of patients, I feel pembro alone is sufficient for the greater than 50%.
Okay.